Let's crack on with the practice. You guys are doing fantastic. Let's get 2 minutes on the clock and your time starts now. All right, time is up and let's have a look at some answers here. Now, sometimes they're going to give you some of the answers in the stem itself. Be wary that you don't get caught out by questions that ask about additional red flag symptoms. So always, always, always read the question being asked. Of course, the big things here we're going to be worried about are things like cauda equina syndrome, so bladder or bowel dysfunction, which can suggest cauda equina. Any kind of worsening or progressive neurology is also going to be worth lots of marks there. Certain risk factors include age. So age over 40 or age under 15 are the two higher risk brackets for back pain. Any kind of unexplained weight loss, any night pain, any history of cancer or new onset of back pain in a patient with a known cancer should also be raising your red flag status. Pain at rest as well. Any history of trauma, obviously not stated in this question, but also fevers over 38 degrees or systemic features of infection that could be there. Tied into that as well, skipping ahead a little bit, is any past or current history of intravenous drug use. You're going to be at much higher risk for things like spinal abscess in that population, and alongside, and kind of tied into that as well, is known immunosuppression can also increase the risk of infections there. All right, let's move on then to question 2. Let's go and get 2 minutes on the clock. And your time starts now. Alright, time is up and let's have a look at some answers here. Now this is a relatively common presentation and so this really should be bread and butter for us. Of course, if it's something you want to read up a bit more, non-radicular low back pain, assessment and evidence-based treatment again from RACGP, a fantastic read. You might have other things on your mind at the moment, fair enough. Of course, number one is to provide reassurance about the benign nature of mechanical low back pain in the absence of red flag symptoms. Sometimes just letting the patient know that there's nothing serious going on. Yes, it can be very uncomfortable, it can be very painful. Back pain sucks, there's no other way about it. But there's nothing sinister and that it should be something that can be fixed conservatively. One of the most important things is to get this patient moving. So encouraging physical activity as tolerated, and tied into that would be avoidance of prolonged bed rest. It's the patients that just sit down in bed and don't move, don't actually mobilize, are the ones where everything seizes up, the pain goes through the roof, and you spend 3 times as long trying to get that patient moving again. For this, you could consider a standard referral to a physiotherapy for guided exercise therapy, or for ergonomic advice, one or the other. Things like Tai Chi, yoga or Pilates, again ties into that. It's about the gentle, sustained movements. And really, really important, I cannot highlight this enough, early return to work, preferably modified duties to reduce the strain. So part of that would be looking at how they're actually moving and how you can avoid further injuries from occurring. They would need to be on lighter duties until their symptoms improve to the point where they can return full work again. Now, acupuncture is still listed as one of the recommended therapies there, along with prescribing some simple analgesics as needed. I think it would depend on the practitioner regarding acupuncture. I'm still not fully convinced of the evidence, but a lot of people swear by it. It is something that is relatively benign until you've seen a couple of nasty cellulitis or abscesses formed from it. Trust your own judgment is what I'll say. Of course, we do have an extra question here tonight, so let's get 2 minutes on the clock and your time starts now. Alright, time is up. Let's have a look at some answers here. Even if you are not a prescriber, you need to have a working knowledge of how this stuff works, and of course the number one thing I would be letting this patient know, there's currently very limited evidence for the efficacy of cannabidiol in managing chronic non-cancer pain. So probably not a role in this case in particular. Also, therapeutic dosing often requires high doses, which can be incredibly expensive. Therapy is not government subsidised, tied into that as well. It interacts with a lot of other common medications, so that would also have to be taken into consideration. And common side effects can include things like fatigue, diarrhea, and appetite changes. So there can actually be harm by trying these things, especially when the role here is limited in its evidence of efficacy. Coming in from the chat here, we have expensive, definitely. Restrictions to driving? Surprisingly, if we're just talking about CBD, no. It's only the THC component that actually causes restrictions to driving. If going through an actual prescribed formulation, it can be certified that it is pure CBD, no THC, in which case the patient can actually drive. If they're going to a dodgy shop down the back end of town and getting it, that's when they're probably going to run into some trouble, and so you would warn them away from things like that. But it's the THC that actually has restrictions to driving, not CBD. Number needed to treat higher than number needed to harm. Perfect, and that's like a really nice, succinct way of kind of combining two of those points there. Not recommended by the College of General Practitioners for pain. Fantastic, fantastic. Smashed it out of the park. And this is something that, again, we probably saw a big flurry of patients requesting this a couple of years back when it first all became legalised. I think enough people have kind of tried it out now, realised it's hellishly expensive, places a lot of restrictions on them, and isn't actually that effective at the end of the day. So I think time has kind of proven this one out.